Good evening and welcome to Caminar's 4th Annual Behavioral Health Symposium. Hope you had a nice tour in the gorgeous gardens. Everything seems to be popping right now. My name is Chip Huggins and I'm CEO of Caminar. We're delighted that you could be here to celebrate Mental Health Month with us. This is a special night for all of us at Caminar as we highlight our programs and research on the interactions of substance abuse and mental health. Our clinicians care deeply in ensuring our clients receive the highest quality of care, and we invest in ongoing training and professional development for our staff. On this night, we welcome you to learn with us about timely topics affecting the health and well-being of our communities. Our focus tonight is co-occurring conditions. If that term is new to you, it refers to coexistence of both mental health and a substance use disorder. We see more and more clients with co-occurring disorders, and this is true for the field at large. Our speakers this evening will share with us risks, causes, and the largest integrated treatments. Caminar has been serving people with complex needs in the greater Bay Area for over a half century. Every day we strive to meet the challenging and diverse needs and severe mental health conditions of our clients. On the journey from crisis to independence, we believe nothing should stand in the way of treatment that improves the quality of lives for people. Last year has been one of growth. I'd like to quickly highlight some of the new services Caminar now offers. Coordinated Entry Program in Solano County. The Healthy Partnership Division was just added in May in Solano. Stepping Stones was added in San Mateo County. We now offer a full continuum of outpatient substance use treatment in Santa Clara County. This spring, we launched the highest intensity of outpatient services for adults in recovery, partial hospitalization. Thanks to the support of the Kaiser Permanente, our programs serving LGBTQ communities in Santa Clara County are expanding. Their efforts to reduce stigma, as you know, stigma too often keeps people from seeking the mental health care they need. Lastly, as of June 1st, Project 90 will become a division of Caminar. Project 90 offers residential alcohol and substance use treatment services. I would like to welcome Jim Stansberry, who had to leave. I'm sorry, Jim, but it's a huge merger for our organization, and combining substance abuse services with mental health is crucial. These efforts speak to the many ways Caminar works to provide integrated care that serves the whole person, from behavioral health, physical health, to housing, to employment, to community and connections. Moderating tonight's discussion are our own 2 executive directors, one from Solano, Chris Kuhn, and Tara Beckman from San Mateo County. Tara and Chris both bring to the leadership of their regions extensive experience working directly with clients, developing programs, and creating innovative approaches to client care.
Good evening, everyone. Thank you, Chip. It is truly an honor to moderate with Chris this evening. So, Chris.
Yeah, no, as Chip touched upon, we're really excited. All of the recent mergers and acquisitions here that really enhances our system of care in regards to behavioral health and substance use treatment. So that is the topic for tonight. Thank you. And we are very excited to hear from our presenters about that. So with Healthy Partnerships, it's a new acquisition in Solano County. They are an outpatient substance use and mental health treatment program. So the whole concept that Caminar is moving towards is integrated care in one place. That's what we have found, and I'm sure our speakers will talk to that tonight. That's what works. That's what helps individuals heal and move forward in their recovery. So one of the things that Tara and I wanted to talk a little bit about is what are we doing currently at Caminar, and tonight we'll also hear more in-depth research about what we can do and hopefully integrate some of this going forward. But for the moment, we'll talk about what we do currently.
Okay, so one of the things that we're really focused on within our day treatment programs, our CRTs, the crisis residential treatment programs, as well as our transitional housing, is the skill building and support groups, as well as within our med clinic. And one of the things that we are currently implementing is more stress reduction techniques and health education, art and exercise groups, coping skills groups, and really looking at how we're treating the whole person. We're also training all of our staff on trauma-informed care, which is a treatment framework that involves an understanding, recognizing and responding to the effects of trauma. So physical abuse, sexual abuse, neglect, abandonment, and all these underlying issues that contribute to substance use issues. Harm reduction and motivational interviewing is also at the core of the training that we provide to all of our employees within Caminar. And then we'll speak more about harm reduction later in our PowerPoint. And then we have treatment plans that are tailored for the individual and identifies the client's goals, and medication support provided within our med clinic, and that is done by the registered nurse and the psychiatrist.
Yeah, and one of the things that we have found that really works is having the multidisciplinary team. So our teams of support for our clients are comprised of psychiatrists, case managers, social workers, peer providers, crucial piece to moving people towards recovery, job coaches, and family. So bringing all of these folks together to the table really helps to coordinate the treatment plan and to help institute success in someone's journey towards recovery. Another aspect of what we do is bringing people together, right? So we have conversations with the people that matter in an individual's life. Tara started these complex case conferences in San Mateo County, which really bring together all the players in an individual's life so everyone's on the same page and everyone can coordinate together effectively. So one of our main approaches is harm reduction. Some may be familiar with this term, some may have some feelings about this term. Really, harm reduction is the idea of reducing the amount of harm an individual does to themselves through their use of substances or through their use of health. It's been used all over the world for HIV reduction and for needle reduction. It's also been applicable to our substance use treatment here. One of the things that we've found is not all of our clients in the Caminar system really respond well to the traditional 12-step approach to abstinence. So one of the things that as we introduce harm reduction, we also bring in the individual's empowerment to work on their own recovery. So making those small steps, using motivational interviewing in concert with harm reduction to help individuals make those choices and acknowledging those choices as they're moving forward has really been very, very successful, in addition to being what really works for our clients. Most of our housing programs throughout San Mateo, Santa Clara, and Solano County are based on a housing first model, which talks about getting individuals into housing and then bringing services to them. So harm reduction is a key component of that. So some folks may think harm reduction, you're not talking about use. The eventual goal of harm reduction is actually the same as 12 steps with eventual abstinence. It's a different approach to getting to that point. So using our motivational interviewing skills, using clients' ability to make small changes in their lives to get celebrated, helps people move closer and closer towards that while giving people a sense of control over their own use.
And then one of the other things with harm reduction is really looking at the client's relationship with the drugs, with the alcohol, and really opening up that conversation with the client and not having judgment, allowing them to talk about it, allowing them to talk about their trauma, and really looking at what are the strengths that you currently possess that can help you take control of the situation versus having a sense of powerlessness over the drug and with the drug. So the goal really is to start having a conversation and being there and being present with the individual to ensure that they have someone that they can come to when they are struggling. And everyone else in their life have said, we are not going to be able to tolerate this any longer, that they still have that individual and or services that they can go to for support.
So we wanted to bring this a little closer to home, not just theoretical concepts. Tara and I are each going to share a case study of real life individuals that we worked with in the past week. Was that one of our phones going? Okay. So I'm going to talk about a gentleman that we serve in Solano County. And actually, for those of you who don't know, Tara and I worked together in Solano County for about the last 3 years, and then she just transitioned down here. So she knows this individual well as well. So this is a 29-year-old male. He has a diagnosis of bipolar disorder and severe opioid use disorder as well. Had been using opioids for most of his 20s. Then most recently was on methadone for the past 6 years. Very much the struggle, and I think that we'll hear, I think Mark speak to this in a moment around the different systems and the challenges we face. So, Caminar services are funded through behavioral health, through the mental health division. Methadone, opioid use, and substance use treatment is funded, in our state at least, through a separate funding stream. Hence the challenge in the holistic care of the individual. So this gentleman struggled for quite some time getting connected to the methadone clinics, which you have to go to get your doses, because he often took more than necessary or didn't show up or tested positive. So the communication and the challenge of getting him on the accurate dose was very complicated. So most recently, he has transitioned to using Suboxone, be our nurse practitioner in our outpatient clinic, which has been going well. But the reason he was in my office the other day is because he mistakenly took a few too many this last few weeks and was out for the month. So it is a continual challenge. So this individual is wrapped around in one of our full service partnership programs, meaning that he's got a case manager, peer providers, he's got a psychiatrist, as well as a nurse and an LVN supporting this individual. So one of the things that we really try to do is wrap people up. And following the Housing First model, this gentleman lost his home due to his substance use. And then we were able to get him into our crisis residential treatment program in Solano. It's called Laurel Creek. It's the Redwood House here in San Mateo County. Was able to transition to Gateway, which is our 30-day transitional housing program where he remains at the moment, attempting to get into permanent supported housing. So anyway, the whole point of this was just to give you a snapshot of how our system is currently operating. Again, we pretty much operate in the behavioral health realm of things. What we're hoping to do with these new acquisitions and these new opportunities is to integrate care so that the whole person gets treated, so all of their needs get met in one place.
Okay, so in San Mateo County, we have a young man, a 22-year-old Caucasian male, diagnosis of schizophrenia and cannabis use disorder, methamphetamine use disorder as well, which we're seeing a significant increase in Solano and actually San Mateo County, and which is also causing an increase in substance-induced psychosis. And in Solano County alone, I know there was about a 75% rate of individuals testing positive for methamphetamines within our CSU.
So when they go to the crisis unit, meaning 75% of the people that come into the crisis stabilization unit test positive for methamphetamines.
Mm-hmm. So this young man has a trauma history of both physical abuse and neglect. He had one suicide attempt and many safety-related issues. When he came to Caminar, he was not able to manage his daily living activities and had walked probably 75 miles to the airport and was then taken into treatment at that point. He was in residential treatment for only 2 weeks and did not graduate the program. However, the case manager established good rapport with him, and I think that's one of the things that we really have to look at is how do we build relationships and allow individuals to feel comfortable just starting to have the conversation, starting to talk about it without judgment, without feeling ashamed of it. And so that's where the dialogue started. While he did not complete the program, he was agreeable to medication support, which did help to stabilize his psychiatric symptoms. And he is now motivated to pursue substance use treatment again. The case manager and the treatment team have continued to have ongoing discussions with him related to his symptoms and substance use, as well as psychoeducation regarding the effects of marijuana and methamphetamines and potential medication complications. So this young man has been complaining about severe gastrointestinal issues and has said, I'm really starting to feel a lot of pain in my stomach. So this is an opportunity to have a discussion with this young man about how methamphetamines can cause gastrointestinal issues. So he at least has the information and the knowledge to make more of an informed decision about what he's taking and whether or not he has the ability to moderate and reduce that level of that drug or alcohol. Some of his successes include stable housing, SSI, so he has Social Security now and an income. He has a REP payee program. He's engaged in treatment with all of the providers. He uses public transportation. He's receiving job training, and he's spending time with friends. He also enjoys doing art and drawing. He has good insight into his mental illness and substance-induced psychosis. So when we look at this young man, we really have to look at the successes and celebrate those successes and celebrate his progress. And this is in turn going to help him improve his self-esteem and continue to want to make strides to ensure that he can be successful and reduce the level of functional impairments in his life.
So part of what we're suggesting, as you'll hear much further tonight when our speakers present their experience, is that one of the ways to engage people is listening, starting the conversation, being able to have the dialogue about people's relationships to substances. Historically, it's been, people are afraid or stigmatized about talking about their substance use, just as they have been around their mental health challenges. What we want to do is to create an invitation to them so that they feel comfortable and safe talking to the treatment providers to get the support that they need. Again, reaching back to our housing first models, and that's what we have found that works, getting people into housing and then beginning to add services and add supports to them throughout their lives. And again, treating the whole person. Many of our individuals have complex mental health, substance use, medical, and social needs. So being able to treat the entire person for what they are showing up for is crucial to recovery. This begins with some psychoeducation, self-care, teaching the folks that we serve to really take care of themselves, access the resources that they need in the community, and to really encourage safe use of substances, if at all. So really providing that education so that people can make informed decisions.
And finally, in summary, in terms of ways that we can all support individuals with co-occurring disorders, is really to strive for any change in a positive direction. So understanding that any step, any success, that we acknowledge that, and that we provide positive feedback when they make those improvements. And that abstinence and moderation are harm reduction strategies. We focus on the strengths and not the weaknesses. We look for any positive change, and we always praise progress.
So we're very excited to have some amazing speakers sitting right in front of you. I would like to begin with introducing our very first panelist tonight, Mr. Mark McGovern. Well, it's only one MC in his whole name, not two, as the brochure says. Dr. McGovern works at Stanford University School of Medicine. He's professor in the Department of Psychiatry and Department of Medicine. He serves as the co-chief of the Division of Public Mental Health and Population Sciences, and is the medical director of Integrated Behavioral Health in the Division of Primary Care and Population Health. That's quite the mouthful, Mark. So prior to joining Stanford early last year, Mr. McGovern was on faculty at Dartmouth School of Medicine, and before that at the Feinberg School of Medicine at Northwestern University. He has dedicated his career to reducing the stigma of mental health and addiction problems. He focuses his work on improving mainstream healthcare with the goal of optimizing treatment and the life outcomes for persons suffering with these issues. Since Dr. McGovern's arrival at Stanford, he has been actively involved in combating the opioid epidemic here in California and nationally by using implementation science to expand access to care for individuals and families impacted by opioid addiction. And actually, he and I were just talking about a doctor in Marin where I live that he had been working with too. So I know he's all over the place doing this good work. So without further ado, we'd like to welcome Dr. Mark McGovern to the stage.
Good evening, everyone. I was thinking, thanks for coming out tonight and prioritizing this over the Warriors game. If anybody's checking the score, maybe you can let us know between speakers. I think the game started at 6. Chris is right. First of all, thank you for inviting me to present to you. This is a topic that's personal to me, as I'm sure it's personal for you. Otherwise, I don't think you would be here on an evening like tonight. And it is a bit daunting, the description in my introduction, but really what I do is I try to get people the best care possible. That's my job. I wanted to thank Chip and Adam for inviting me to come, and Tara and Chris. It's an awesome presentation about the kind of services that you offer here. It's really good to hear about the quality of care and how you are working towards integrated care. And I'll have a chance to talk a little bit about that this evening. It's also pretty ironic. Myself, I'm only in California about 15 months. I came from Dartmouth in New Hampshire, as you heard. I'm a Vermonter, and here on the panel with me are two people who I knew and loved in New Hampshire and at Dartmouth. So you have three people from Dartmouth here. Dr. Fisher's been here 3 years, the longest, and Doug, I guess, about 2.5 years or so. So it's, I don't know how that happened, but we have three New Englanders who can talk about, in fact, Doug and I were just talking about septic and wells, things like that, so it's pretty funny. Here it is. Derek is a 32-year-old African-American who served with the U.S. National Guard in Kandahar, Afghanistan. He returned home to his job as a driver with the National Delivery Company, and he found himself experiencing nightmares, flashbacks, and insomnia. This led to increased alcohol use. He got Klonopin from a doctor to help him with his sleep, and he got oxycodone for pain in his neck. Subsequently, he got a DWI, driving under the influence, related to alcohol, and his lawyer suggested that he get an evaluation and maybe a treatment plan, a treatment to offset any legal consequences. He got an evaluation. He did not trust the VA, so he went to a private addiction outpatient treatment program recommended by his lawyer, where he was diagnosed with alcohol, sedative, hypnotic, and opioid dependence. The program recommended their own intensive outpatient program for his substance use problems. No one asked about his traumatic experiences in war or combat exposure, and no one actually asked him if he was a veteran. Anthony is a 19-year-old college student, a freshman with poor grades and high expectations. He's from a first-generation Mexican-American family. He went to the school mental health clinic because of social fears, anxiety, and avoidance of many situations where he felt that people were judging him negatively. In the evening, he smoked blunts, large marijuana cigarettes, and snorted, along with some of his roommates, the crushed-up ADHD medication. He was evaluated at the school mental health center with social anxiety disorder. The recommendation to address the adjustment to college life, he was actually asked to fill out forms when he came to the clinic and he said yes to questions about his drug use, but no one ever asked him about it after that. Nancy is a 42-year-old divorced Caucasian charge nurse on a medical surgical unit of an academic medical center. She presented to her primary care doctor with depression related to her recent divorce and single parenting stress. She asked for medicine and got an antidepressant. After about 6 months of being on the medication and not really feeling any better, her primary care doctor insisted that she have a conversation with the embedded social worker who worked at the clinic. At first, during the conversation with the social worker, Nancy did not admit to her alcohol use, but her lab test revealed an elevated liver profile with which the social worker brought to her attention. And when this happened, Nancy acknowledged that she drank 1 to 2 bottles of wine every night. And she's also depressed. The recommendation was an integrated treatment program that had the expertise to address her alcohol use disorder and her depression or mood disorder at the same time, at the same place, and by the same treatment team. What can I tell you? Can you all read this? Okay. What I can tell you about co-occurring disorders are that they're common in the general population and even more common in clinical settings. They're associated with negative outcomes. Integrated treatments are associated with better outcomes, but no more than 10% of people with co-occurring disorders get integrated treatment. I'm happy that Chip explained what co-occurring disorders were. Some places they think, what are you talking about, hypertension and diabetes? What are co-occurring disorders? But I'm guessing this audience knows what we mean by that. So there's an enormous implementation gap. We have an effective treatment. 90% of people don't get it, right? That's a huge disparity. Would you agree? Quite simply, 2 out of 3 people with a substance use disorder have a psychiatric disorder, typically mood or an anxiety disorder, but also bipolar disorder and other more severe forms of mental illnesses. 1 out of 3 people with a psychiatric disorder have a substance use disorder. So it should be the expectation, not the exception, right? What kind of negative outcomes? Worse symptoms and suffering, more struggles and more challenges in day-to-day functioning, less benefit from treatment, and using more costly services like emergency departments and hospitals, and increased exposure to trauma and victimization. Given that they're the expectation and not the exception, why not treat both at the same time, right? It seems like it would be the logical thing to do. So I put the word bifurcated, which is a fancy word for split. Mental health providers are kind of on one side of the street, and traditional addiction providers are on the other side of the street. So if you talk to a lot of mental health providers, here's what they say the problem is. Well, we don't have good training. Those kind of patients require different types of skills, and maybe even we need different types of settings. We need rehabs, we need detoxes, we need very special places that contain folks with the substance use problem so they can't get to the substance. And I've heard here mentioned earlier stigma. Mental health providers often have stigma about people with substance use disorders. Mental health providers might also overemphasize the underlying causes. If we get to the place where we really understood why you drank or why you used drugs, then you would stop using them in this problematic way. They often neglect the neurobiological bases to the attachment that people have to substances. And they minimize the depth of the attachment to the substance. You heard our previous presenters talk about the relationship. Well, it's an intense relationship. It's like a hijacking of a person in that relationship. What about the other side of the street, addiction treatment providers? It's kind of the same list in some ways. Inadequate training, stigma, different types of skills and settings are required. Addiction treatment providers often feel that they aren't really aware of the high prevalence rates and the negative consequences of having a co-occurring disorder, and oftentimes have a one-size-fits-all approach, which is, as Chris mentioned, an abstinence-based approach. There are many roads to recovery, and integrated treatment is one of the best ones for people with co-occurring disorders. The typical approaches that are not integrated, I think we know about these: a single problem approach, where there's treatment of one or the other, but not both. In the case of Derek, and Anthony. Even the other disorder was not even identified. Sequential treatment, where we sort of feel like, okay, we'll treat the one that's primary, and then once that's stabilized, we'll get to the other one. Good example of that is someone who has a substance use disorder and post-traumatic stress disorder. We'll get you to stop using substances, and then we'll deal with your PTSD symptoms. Or maybe we'll address your PTSD symptoms and then get to your substance use disorder. Neither of those approaches are effective. Parallel treatment, and this happens a lot in a community like this, where there's two different separate groups of providers. You mentioned the funding streams in California that pay for services differently. So you might get care to address your substance use problem in one place and care to address your mental health problem in another place. Do the people interact? Your providers interact and talk to each other? It's very inconvenient to do that. It takes a lot of time. It's often not billable time. So integrated treatments, you've been hearing a lot about. They work best. They reduce harmful substance use and are associated with increased abstinence. They reduce psychiatric symptoms, better work and school functioning, reduce hospital and emergency use, improve quality of life and recovery. So the opposite of all those negative outcomes sort of lined up here. So this is a really interesting question. Did anybody see John Oliver's segment on rehab on Sunday night? It's pretty impressive. I could talk all night about that, but I was only given until 10 o'clock to talk, so just kidding, 30 minutes. How do you know if you're going to get integrated treatment? So if you're consumers of services or family members of services, or you're thinking about making a referral for services, well, you ask the providers of those services, right? Do you offer integrated care? John Oliver played a clip where one of the well-known private $73,000 for 30-day rehabs in Southern California, Malibu, said, we have a 100% cure rate. So that's what one provider of services said. You ask former patients, right? If you ask a patient, did they treat both your substance use and mental health condition during your stay at this program? That would seem like a pretty good source of information, right? And what about objective standards? If there are any such objective standards that might tell you, a la kind of consumers reports, in a way that you would know would be kind of verified, standardized, if you will. So providers, if you ask organizations what they do, and there's no good way to get at this for traditional mental health providers. The Center for Mental Health Services does not really ask this question. They don't really keep an encyclopedia or directory. The Center for Substance Abuse Treatment, that's ultimately under the auspices of the Department of Health and Human Services, does ask addiction treatment providers, and 84% will tell you they offer integrated care. A lot of surveys have been done, and about 75% of places will say we offer integrated care. If you look at the marketing materials, 100% say they offer integrated care. So if you're a consumer, it's caveat emptor, right? That means you really have no idea, based on that report, if you're going to get integrated care. That's scary. So I often show a screenshot of an email I get. I actually had a phone call this morning about a person looking for integrated care. So what do consumers say? Can you see this? It's very large. I'm from Vermont, so this is a cheese chart. It's not a pie chart. So these are surveys. I'm sorry I don't have more recent data. It hasn't changed much. But the consumers were surveyed in National Household Survey. The survey says basically, you have a co-occurring disorder, and they're able to gather that information from the survey. Majority of people, 56%, don't get treatment. The next largest number get care for mental health problems only, which means their substance use is not being addressed, which means there's chances for a positive outcome are, let's say, less than average. The next group says both mental health care and treatment of substance use problems, 8%. So I said less than 10% on that first slide, right? So it's closer to 8%. But this could also mean they're getting care for their problems, but in 2 different locations. And I said earlier, maybe it's a wild assumption to think that the care providers are actually communicating and coordinating and on the same page in treating an individual. And then this tiny little slice, people getting treatment for their substance use problems only. It turns out informed patients, as you guys probably would agree, want integrated treatment, right? If you know about it, then this is what you want. And there's actually been a bunch of studies, 27 studies, that have confirmed that. Patients prefer integrated treatment. They want care for the same problems by the same people at the same time in the same location, and they want it delivered potentially in a team, much as Chris described. So what if we had an objective standardized measure of the degree to which a program offered integrated care? It could guide systems and providers on how to do it. It could guide consumers and families on how to make informed decisions and where to go. So we got, in my period at Dartmouth, involved in developing standardized or organizational measures of integrated service capacity. The first one is called the Dual Diagnosis Capability and Addiction Treatment Index. The second one, Dual Diagnosis Capability and Mental Health Treatment Index. And this last one, which we're working on most currently quite a bit, is called the Behavioral Health Integration and Medical Care Index. It's formerly known as the Dual Diagnosis Capability in Healthcare Settings measure. So it's a DDCAT, DDCMHT, DDCHCS. Now, people want to shorten acronyms, right? They don't want to say all that, so they say the DDCAT, the DDMUT, the C is silent there, and then any with the DDCHCS, anybody want to venture what that might be called? The DD-CHICS, right. So the DD-CAT, the DD-MUT, the DD-CHICS, a barnyard of organizational measures. Well, how do the measures work? Well, we go to an actual program, we observe, we interview everyone from patients to the director, we review documents, we do what an old ethnographer, anthropologist friend of mine called deep hanging out. We try to observe and find out what's really happening in the program during the course of about 3/4 of a day. It derives standardized objective scores on actually 35 benchmarks, and it ultimately describes or categorizes the program as addiction-only services or mental health-only services, dual diagnosis capable or dual diagnosis enhanced. So really 3 categories. The more integrated, the more it gets to dual diagnosis enhanced. Sort of partially integrated is dual diagnosis capable. We had a national project funded in part by the Robert Wood Johnson Foundation, funded by the National Institute on Drug Abuse, National Institute on Mental Health, and Substance Abuse and Mental Health Services Administration across 13 states, very different states. Addiction treatment agencies, and this is another cheese chart, where the majority, i.e. 81%, were addiction-only services, not offering integrated care. 18% and 1% were dual diagnosis capable or dual diagnosis enhanced, respectively. So you get a 1 in 5 chance, perhaps, of getting integrated care in these addiction treatment programs. Now, the next slide I'm going to show you, and sometimes people get PowerPoint slides printed out ahead of time. That sort of ruins the suspense if you're a presenter. So the next slide is for mental health agencies' national data. Now, would you hypothesize that mental health agencies would be more likely to offer integrated treatment or less likely to offer integrated treatment than traditional addiction treatment programs? Who would say more? You're wrong. Sorry, couldn't resist. Mental health agencies, 9%, so 1 out of 10. Half as many as those addiction programs. What's up with that? Psychiatrists, psychologists, master's level clinicians, more money? Why not offer integrated treatment? So the good news is that many of these programs participated in a funded project where they volunteered for the most part in trying to improve the integrated service capacity within their organization. And the addiction programs, and this was 103 programs that we had baseline and follow-up information on, 54 mental health programs that we had baseline and follow-up information on, roughly 18 months later. So during those 18 months, they did some things, and I'll talk about what they did. Good news is that change is possible, right? So it went from 14% to 44% of addiction programs. So that's a pretty good jump to become integrated in 18 months. Mental health programs, again, a relatively small number, half of those, of the same number of, not the same number, but the percentage of addiction treatment programs went from 7% to 32%. So the good news is that if a program focuses on this issue, they can begin to offer integrated services. So you heard me mention that we're interested in organizational measures, and we try to measure things in such a way that other organizations can replicate and learn from those things, and we have these measures standardized. So we developed another measure called the Implementation Index, or II, to identify what successful programs did in making those changes over the 18 months. I mean, you might say, well, Mark, they must have gotten more money in order to do that. They must have gotten all sorts of training, train up everybody. It turns out those things were not associated with that kind of change, the magnitude of change. And most of the people that do implementation research like I do will tell you that training is ultimately not effective in changing practice. Money can be, but it's not a given. Leadership support was. So Caminar, you have great leadership support for integrated treatment. Maybe that's why a lot of good things are happening in that direction. Measurement was, to the extent that they were measuring changes in small ways. The number of patients we screened, the number of patients we followed up on with a positive screen for substance use or mental health symptoms. Having a planned implementation strategy was too. Now I have to tell you, we thought we had gotten out of the barnyard of organizational measures. So I thought implementation index, II, there's no animal that's associated with II. I did this presentation in Washington a few years ago, and someone brought up their cell phone and said, Mark, and he showed me this. Anybody here from Madagascar? This is the II. Yeah, it's a nocturnal animal, a little bit smaller than a raccoon. It's about this big, I understand. Comes through the villages, and if people in the village see it come through the village at night, someone in the village will die. That's folklore. There's no evidence that showing you the picture of the II will cause death. So here's a project we're currently in the middle of in Washington State. In fact, I was at Olympia on Monday and Tuesday this week. Up the road, we're using a very focused manual guided implementation strategy, a process improvement strategy. Many of you people might know about Lean or Six Sigma. Has its origins in managerial science and the business world. A version of that called NIATEX. It's a funny name, but that's what it's called. We've had 50 behavioral health organizations in the state of Washington, from Seattle to Pullman and everywhere in between. 35% of them were dual diagnosis capable, 4% dual diagnosis enhanced. So these were volunteer agencies. So 39% were already pretty far along in terms of their integrated service capacity. At 1 year, so not that long of a period of time, that number jumped up to 74%. So you want to see that green part of the cheese chart shrink. That's what we're wanting if our goal is to get people the best care possible, right? Sort of what my goal is. We compared the people that got Niantex to this wait list group, so they had to wait a year. They're actually getting it this year. And even the wait list people, just getting their measure, just getting the feedback about what their scores were on this measure, kind of like looking in the mirror or looking on, stepping on a scale, getting feedback, turns out to have precipitated quite a lot of change, right? So they took their scores and ran with it. So that's good news too, right? So I guess what I want to say is that we have effective treatments, we have things that work, and we have people that need it but don't get it. I have a colleague, Russell Glasgow, who works for the National Cancer Institute, that we should have a moratorium on new discoveries for things that work until we can figure out how to get the things that work to the people who need it. And so much money, actually it's the rates are staggering what we spend, what the federal government and the biomedical research industry spends on discovery is about 100,000 to 1 in terms of discovery versus implementation. So I'm a very poor implementation scientist, is that's what I'm saying. The idea I wanted to talk about a little bit, because it's one of these things again, is the opioid epidemic. I think anybody who doesn't know about overdose death and the opioid epidemic, whether it's prescription drugs or heroin, in some cases fentanyl. I think fentanyl is creeping its way into the West Coast. It has hit New England, Massachusetts on up, actually Pennsylvania on up very hard, very much associated with overdose death. So the opioid epidemic has caused, influenced a lot of increased attention towards behavioral health issues. Doctors maybe feel partly responsible for overprescribing pain medicine, right? There's this overdose death, 66,000 people, estimated maybe even closer to 90,000, just based on what is not written on death certificates by coroner. But by the way, 400,000 people die per year from nicotine, tobacco. 90,000 people die per year from alcohol. So they both sort of win versus opioids. But opioids death is sudden and often unexpected. Alcohol and tobacco death is more insidious. So that's a sudden death part. So there's a huge amount of money, unprecedented amount of money. President Obama signed the 21st Century Cures Act, which was billions of dollars farmed out to the states. There was a lot of fear that the current administration would redirect those funds, but it didn't happen. They actually came out to the states. California got actually the largest share of that money, $48 million per year, distributed to 19 opioid treatment programs who are trying to build capacity within their neighborhoods or networks so that more people can get on the medicine. So a lot of the emphasis in the response to the opioid epidemic is around three things. One is changing prescriber behavior, sort of de-implementing using pain medicine. The second thing is getting Narcan, which is a reversal agent, in the hands of just about anyone who's anywhere near someone who might overdose. Family members, first responders, emergency departments, citizens. And then the third thing is increasing access to medication-assisted treatment, these FDA-approved medications that work and the people who need it. The other thing is that there's a lot of new emphasis, in part because of guilt, I think, in part because the insurance has kicked in to cover the treatment of opioid use disorders in the same way as most other physical disorders. So a lot of primary care doctors, emergency departments, OBGYNs, physicians all over are really interested in treating opioid use disorder and addiction in a way that, I've been doing this for a long time. I've never seen it before. Usually we talk about a push-pull dynamic where we're trying to push something into clinic settings that we think is effective, and the pull is that the clinic settings actually want something. So it always works better when there's a pull, right? The push is like salesmanship. We try to sell them on this thing that they're not really sure is worth doing. There's a lot of pull for learning how and dealing with opioid use disorders in primary care practices right now. The interesting thing is, there's a little bit of deja vu all over again. We're really focused on getting the medication, whether it's methadone or buprenorphine, otherwise known as Suboxone, or Vivitrol, which is an injectable medication, also associated with good outcomes for alcohol use disorder. So the major focus is getting the medicines to the patients, getting the medicines to the people. And the issue is often that we're not paying attention to these other comorbid conditions, like in Derek's case, right, PTSD. So Derek's chances of getting treatment for PTSD were slim. His chances of getting medication for his opioid use disorder significant. What are his long-term outcomes going to be if he doesn't get treatment for his PTSD and his opioid use disorder? People are shaking their heads. So that's the story. I put from 5 to 50,000 feet. I don't really know if we went to 50,000 feet, but I went from Derek to systems of care, and I'll be here for questions. Thank you for your attention.
Thank you so much, Dr. McGovern. That was wonderful. Thank you. So I'd like to introduce our next speakers, Dr. Douglas Nordsey and Dr. Adina Fisher. So Dr. Douglas Nordsey is a clinical professor, associate chair for clinical integration and coordination, director of sports psychiatry, and co-director of the Inspire Early Psychosis Clinic in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine. He also directs BrainX, a collaboration to study the effects of exercise on the mind and brain. Prior to coming to Stanford, he is also at Dartmouth's Geisel School of Medicine. Dr. Nordsey's research interests include medication and psychosocial treatments for individuals with psychotic disorders, methods to facilitate recovery and promote achievement of optimal outcomes for people with schizophrenia and bipolar disorder, and methods to prevent progression of early psychotic disorders. Dr. Fisher is a resident physician and postdoctoral fellow in the Department of Psychiatry and Behavioral Sciences at Stanford. She studied brain and cognitive sciences at the Massachusetts Institute of Technology before earning her MD and PhD in neuroscience at Dartmouth School of Medicine. Her dissertation research examined the effects of smoked cannabis and oral THC on brain circuitry in patients diagnosed with schizophrenia and cannabis use disorder. Through her current research, Dr. Fisher is examining neuroimaging, behavioral and clinical correlates of resilience and psychopathology, investigating differential predictors of treatment response as they relate to quality of life measures, emotional regulation, and cognitive function, and developing pharmacological interventions that better preserve and treat cognitive capabilities in mood and anxiety disorders. Please help me welcome both Dr. Nordsey and Dr. Fisher to the stage.
Thanks, Tara. We're going to go in sequence, and Dr. Fisher's other qualification is that she's a mom, and so she's tending to her baby right now, but if we get to her part, we can always get her back here quick. Let's see if that advances it. So we're going to focus a bit on marijuana and its interplay with schizophrenia and psychosis. And Dr. Fisher and I, when we were both at Dartmouth, worked together on a research project where we looked at the direct impacts of marijuana, both THC in pill form and smoked cannabis, and its impact on brain function in people with schizophrenia. So when I got invited to come here, I immediately thought of Adina, who's a real science star. And so the way we kind of set it up is I'll sort of go at the beginning and a little bit at the end to sort of set the stage and talk about the clinical connections, and she's going to give us really the hard science behind it. So this is kind of our outline, and I'll hit the first three here, talking about cannabis use and its impact on risk for cannabis use disorder as well as psychiatric disorder. and then a little bit about cannabidiol, which is one of the components in cannabis, and its potential impact on psychotic disorders. With legalization of cannabis spreading across the United States and now coming to California, we see trends where the rates of cannabis use are rising, as well as the rates of cannabis use disorders are rising in connection to those. And Dr. Fisher will give some figures on that in a moment. We actually are part of a group that may be looking at collecting data on this as legalization unfolds in California to see how those rates of both use and use disorders are impacted. So in 2015, it was estimated that about 4 million Americans had a cannabis use disorder, and it's identified as really the primary side effect of medical cannabis. Again, that doesn't get talked about a lot. Just, we worry a lot now about opiates, and if you get prescribed an opiate for pain, you could potentially become dependent on it. When you go to the dispensary to get your medical marijuana, they're probably not talking to you about, hey, one of the things that might happen here is you could get addicted. Okay, so an important side effect concern. And people with schizophrenia are particularly vulnerable to developing dependence or abuse of substances. In our experience at our Inspire clinic here at Stanford, where we care for people with early psychosis, we find, as we do in all psychosis treatment programs, that cannabis use is very common in the lead up to psychosis, that people, probably half of people that we do an intake on have had cannabis use as part of the time period leading up to the onset of their psychosis, maybe even a little higher. And many of those folks struggle with being able to stop using cannabis when it's been identified as part of the onset of their psychosis and a complication of that disorder. And many of these people have a very strong affinity for cannabis. They really get very connected to cannabis use in culture and really feel like it's important to them, and will continue to go to great lengths to use it despite the impact on their mental health. And we do know that continued cannabis use increases risk for relapse into further episodes of psychosis, which of course leads to a more treatment-resistant illness. And we do see a lot of attempts at substitution, and the question about cannabidiol comes in because, of course, the folks that at the dispensaries have all kinds of different varieties of cannabis that you can choose from with different percentages of THC and cannabidiol, and so the word has certainly gotten out, and people, my patients come and tell me that, the person at the dispensary told me, that this form is the, is the psychotic form, and this form is the good form, that's going to help me out. And so you see a lot of that in people trying to manage their use. And so this is a very old slide from a nationwide study looking at rates of various psychiatric disorders. And this is the rate of substance use disorders in people in the general population, as well as people with a variety of psychiatric disorders. And PTSD was not part of this study. It was kind of just emerging as a diagnosis at the time that this was being done. And you would see a fairly high rate there. But remarkably, people with schizophrenia and bipolar disorder have some of the highest rates of comorbidity. They're some of the most vulnerable people to developing a substance use disorder, which is really what motivated the research that Dr. Fisher is going to be talking about. Why is it that if having a psychiatric disorder bumps up your risk of developing, a substance use disorder, somewhat higher, why is it that these folks with these sort of more psychotic disorders have an even higher rate? And what is it about that vulnerability? And that's sort of the neurobiology that we were digging into there that we'll talk about a bit more. But certainly a very common problem. And again, counterintuitive when we recognize that cannabis use increases risk for onset of psychotic disorders. It's a known side effect that anybody can have from using cannabis and get paranoid. They can feel uncomfortable. They can have derealization and depersonalization experiences. So many, many studies show an association between cannabis use and increased risk for schizophrenia. And it's led to a number of hypotheses that, again, Dr. Fisher is going to go into in more detail. Sort of what's the chicken and what's the egg here, and to what degree does cannabis use trigger onset of psychosis in vulnerable people? There's certainly evidence for that I'll show you in just a moment, as well as that something about the process of an evolving psychotic disorder may increase the vulnerability to using substances, and there's been a variety of reasons for that identified, maybe some shift in social marginalization as people develop an illness, getting into substance using groups, sort of trying to manage the sort of dysphoria or the icky feelings that go with developing a psychiatric illness, or this concept of reward deficiency, which we're going to spend some time talking about, sort of impairments in the ability to experience pleasure. So this was an interesting study done now a decade or so ago, I guess almost 2 decades ago now, following a group of a little over 1,000 people, basically from infancy all the way through young adulthood, and looking at a variety of outcomes around psychiatric disorders. And they assessed substance use disorders as well. And so they wanted to ask this question: what impact does cannabis use have on the development of schizophrenia? In this case, schizophreniform disorder, which is the first stage of schizophrenia. And so they had information from age 15 and age 18 about people's use of cannabis. And it turns out, about 1% of people in the general population will develop schizophrenia at some point in their lifetime. And it turns out if you had started using cannabis by the time you were 18, you had a 5-fold increase in your risk of developing schizophrenia. But if you started even earlier, by age 15, you had a 10-fold increase in your risk of developing schizophrenia. So earlier exposure to cannabis associated with higher risk of developing schizophreniform disorder, which is, again, the earlier precursor of schizophrenia. And that was also distinguished to some degree by genotype. So just in a simple way to say this particular gene, COMT gene, that's been associated with risk for schizophrenia, was the version of it, the Val version, which is the version that's associated with schizophrenia, led to a much higher risk for developing schizophrenia if you had the risk gene and were exposed to cannabis as an adolescent. So it showed an interaction between the genes and the vulnerability driven by substance use. So a simple way of saying that is that cannabis use can bring out a vulnerability in a person who may be at risk for developing schizophrenia. And as Mark mentioned, I think we all have this in our slides, using substances when you have an illness like schizophrenia worsens basically all the important parameters that when you have and it just makes logical sense, right? When you got another disorder going on at the same time, it's going to be harder to respond well to direct treatments for schizophrenia, and it's going to lead to earlier onset of illness, higher rates of relapse, and this is important, actually, higher rates of non-adhering to treatment, so that prescribed treatments with medications and other treatments for people with schizophrenia aren't followed through with as much when a person's using substances. And obviously, there's a lot else going on in someone's life. It's harder to remember to take that dose of medication or to want to take that dose of medication when you're involved in substance use activity. And increased costs of care, as Mark mentioned as well. And this is just a study looking at people in their first episode of schizophrenia, that showed that about a little more than a third of them had a substance use disorder. That's what SUD stands for, and this is cannabis use disorder. So almost a little more than a quarter having a cannabis use disorder, and then about 20% having an alcohol use disorder. The people that had a cannabis use disorder in this study had an earlier onset of illness, had worse positive symptoms, that's things like hallucinations and delusions, but less severe negative symptoms, so social withdrawal. But the people with the substance use disorder had a longer duration of untreated psychosis, so they went longer before they got care, and had a lower response rate, and that's what the graphic there is showing, is response to first medication treatment was significantly lower in the people that had the co-occurring substance use disorder. This is an older study from Holland showing that people who continued to use cannabis after first episode of psychosis also had higher rates of relapse into a next episode of illness after remission. So the next question is about cannabidiol, or CBD, which again, if you go to the, which I haven't, but I understand if you go to the dispensaries, they'll talk to you a lot about. So cannabidiol is the sort of second most common compound in cannabis besides THC, which is the more psychoactive compound, and it's one of many cannabinoids in cannabis, but that accounts for about 40% of the cannabinoids, and THC a bit more, depending on which strain you're using. It's an interesting compound that has some antagonistic effects at the cannabinoid receptors, as well as some other actions, one of which is a serotonin 1A partial agonist, which is actually an activity that a few medications that help with anxiety also have. So it's been thought about as potentially being helpful, potentially blocking the effects of THC, and potentially being helpful in psychiatric disorders. And there's some preliminary studies that show that. Important to, and this gets into thinking about, what is this cannabinoid system we have in the first place and why do we have it? And again, an important theme to keep, we don't tend to think about this as much as with cannabis as we do with other types of drugs like opiates or amphetamines, which clearly copy natural systems in the brain. But we have an endogenous or natural cannabinoid system in our brain that's there for a reason. It's one of the least well understood circuits in the brain. It hasn't been studied as well in part because of the lack of accessibility to these compounds to study, and that's becoming a little more common. But the two sort of most common components of cannabis, THC and CBD, are mimicking the two endocannabinoids or natural neurotransmitters we have in our brain, which is AEA or anandamide, and then 2AG, which is 2-arachidonyl glycerol. And if you can say that 3 times fast, you're doing pretty well. So again, like most other substances that we use, a substance is sort of imitating a natural system, and so THC and CBD are copying these natural endocannabinoids. And the cannabis system, the cannabinoid system is there to regulate a variety of physiologic and cognitive processes. It's related to various fertility components, appetite regulation, pain, mood, memory, and of course these are some of the things that we know that cannabis impacts. And so these two guys, AEA and THC, seem to have most of their effect at cannabis CB1 receptors and activate them. Interestingly, released after intense exercise, at least AEA is. And if you think about what happens when people smoke cannabis, there are some connections, right? The increase in appetite and the kind of calm, relaxed feeling that people have after exercise is sort of mimicked by cannabis use in some ways. Whereas the 2AG is acting on both the cannabinoid CB1 and CB2 receptors, seems to be involved in appetite regulation, immunity, and pain. And again, another thing to keep in mind is that whenever we use an exogenous substance to stimulate an internal system that's usually in balance, we're going to often tip that balance off, right? So if I have a cannabinoid system in there that's helping me to, feel good after I exercise or to stimulate my appetite at appropriate times, and I start, saying, gee, I'd like to get more of that, and using cannabis at other times, I may, disrupt the ability to get those experiences. Again, there's many claims about cannabis, most of which are based on minimal science. We actually had an expert from Columbia here 2 months ago at our NeuroChoice group who has been doing some work trying to really sort of verify some of these claims, and found that pain regulation is the area that they've been studying a lot and has probably the best evidence, but that many of the other claims that you see for cannabis, of course, are being made by the people that sell it, and just like, all those ads you see on late night TV where they want to sell you the latest thing that's going to solve all your problems, you have to have a healthy dose of skepticism for them, as well as, recognize that they may have some basis. So there have been 2 studies now looking at CBD in schizophrenia. One that was done, and actually both of them were done in Europe. One was a comparison of CBD to amisulpride, which is an antipsychotic that's only available in Europe and in other parts of the world. And this more recent one that was actually just published 2 months ago in the American Journal of Psychiatry looked at the addition of CBD to ongoing therapy with an antipsychotic medication in people with schizophrenia who had less than complete control of their symptoms. So partial response to medications. Relatively small study with about a little more than 40 people in each arm, and it was a 6-week randomized trial where people would drink 10 milliliters of liquid that either had CBD or placebo in it twice a day for 1,000 milligrams a day total. all people with schizophrenia or schizoaffective disorder, and they continued their prior medication without change. And it turned out that people who got the CBD did show greater reduction in their PANSS positive score, which is the PANSS is a commonly used rating scale for schizophrenia trials that measures a range of symptoms, and the positive subscale focuses mostly on symptoms like hallucinations and paranoia. Although that reduction was a little, 1.5 points greater improvement in the folks who got CBD compared to the folks who got placebo. Both groups improved. There was also more people in the CBD arm were rated as improved, and fewer were rated as severely ill, again by small margins. And there were a range of other measures where there were not differences found. People that got the CBD had more stomach upset related to it, but actually seemed to have less sedation and insomnia than the folks who took a placebo with their medication. And this is just showing you the outcomes. So in these bars, the green bars are the folks who got cannabidiol or CBD, and the orange bars are the folks who got placebo. And you can see across day 8 and day 22 and the end of 6 weeks that the folks who got CBD, this is showing more improvement, so a reduction in the positive scale there, although the error bars are overlapping, so it's not a huge difference. It was statistically significant, and this is again that improvement rating scale, so by the treating psychiatrist, where you can see the folks in the green bars have somewhat higher rates of improvement, and the folks who got placebo were generally viewed as not changed, although on the minimally worse, you actually see a few more with the cannabidiol as well. So, an interesting, promising finding in a pretty small group of people, and I think their conclusion was well-founded, which is that it needs more research, but looking like it's taking us in an interesting direction. From a treatment point of view, as a provider, I certainly don't. My colleague Jake Ballin said this a couple days ago when we were having this discussion. I certainly don't feel like I would write a prescription to somebody, tomorrow for CBD, in part because there's no reliable source. In this study that I just showed you, they had a pharmaceutical company that was sponsoring it that synthesized pure CBD for them. But when you go to the dispensary and they give you something that says it's mostly CBD, you don't really know. In fact, studies that have looked at the composition of the stuff that you buy, the labeling isn't that accurate in terms of how much THC versus CBD you get. And it's very hard to get a product that's CBD only. It usually has some component of THC in it. And also, my patients tell me that getting high CBD products are also more expensive than getting regular, cannabis. And so, one of my patients who was trying to use CBD alone, found that he was getting to the point where he couldn't afford it, so he just would slip back into getting the regular or higher THC cannabis, which is a common thing that when people are using it for a substitution, just like drinking, alcohol-free beer, it kind of doesn't get you out of the mindset and the framework, so it's pretty easy to slip back into using what you're used to using. And we don't know to what degree cannabidiol may carry some of the risks that cannabis has of impairing motivation and cognition and producing sedation, although the study that I just showed you didn't find, they did measure cognition and sedation and did not find that those worsened in people that got CBD. So at this point, what we find is probably the way that we end up advising people around CBD is mostly as a harm reduction strategy, which is that for folks who are using cannabis anyways and are not able to sort of follow a recommendation to not use cannabis, that will then encourage them to tilt their use towards more CBD-containing compounds, which do at least seem to be safer for them and potentially may have beneficial effects as part of their treatment. So I was going to just talk a little bit about the brain reward system, which again, Dr. Fisher is going to give us the science about, but I wanted to kind of set the stage a little bit to think about this circuitry we have in our brain called the brain reward circuit and why we have it, what it's for. It's something that sort of is designed, if you think in an evolutionary way, to sort of help to get us to do the stuff that keeps us going. So You get reward from eating good food, from falling in love, from intimacy, from a good hike in the redwoods, or winning a state championship. You know, those amazing things that happen that have a neurobiologic basis in dopamine and endorphins, and it turns out actually cannabinoids, and the natural cannabinoids are part of that sort of reward signaling. But that's there to sort of get us to sort of experience positivity from these great experiences and to do it again, right? So having social relationships, procreating, eating good food keeps the species going. It keeps us happy and connected to things that are helpful. It's associated with people, activities, settings, and items. It's sort of that here when I'm talking about craving and reward, when you think about that amazing watermelon you had at 4th of July picnic last year, it makes you think about getting watermelon again, or that great turkey dinner. So sort of a natural reward response reinforces the healthy lifestyle, reinforces achievement, and keeps the species going. It's sort of connected to things that are meaningful and helpful. So what if you could bottle that feeling, that wow, we just won a state championship, So you could feel like you won a state championship anytime you wanted to. Well, that seems like a great thing, but it's all the reward without the achievement, right? And of course, this is the problem with substance use and substance use disorder. Any substance that can lead to addiction, in addition to its sort of direct target, triggers this brain reward system and sort of stimulates that whole dopamine cascade that we were talking about, triggers this brain reward circuit and gives a fake reward signal, right? I can, I was actually listening to the news this morning and they were talking about closing some BART station hallway because, everybody's shooting their heroin there. And I was thinking about, so I can feel like I just won a state championship when I'm lying on the cold concrete in a BART station, so you can create this like, wow, and do it again and do it again and do it again. And again, that's the definition of addiction, isn't it? That you're compulsive repeating a behavior because this reward system is getting turned on and it's very hard to not repeat it. So this system that we have that's there to help us to be healthy and keep ourselves and our species going is getting derailed into repeated substance use. And of course, the associations you have now aren't about my team and my coach and the great work that we did to win that state championship. It's about the money and the sex I had to give to get the drugs and the dealer and the drug use rituals that then become the things that trigger that sort of craving and reward circuit. So with that, I'm going to turn it over to Dr. Fisher, who's going to dig into the science behind what is this reward circuit thing and how is it connected to cannabis use, and I'll let her pick it up from there.
So I'll start maybe before going into the details of the underlying neuroscience and neurobiology of cannabis and its effect with respect to co-occurring mental health disorders by saying that right now I'm about to complete a 6-month rotation at the Counseling and Psychological Services Center at Stanford University. The students that I work with are all incredibly bright, incredibly talented, needless to say. And yet I can think of countless examples of students that come in because they're unable to concentrate. They're no longer motivated to do their work. They're self-isolating in the room. Some of them are experiencing psychotic symptoms, sometimes as severe as thought blocking. And what they have in common is that they are, 1, meeting criteria for cannabis use disorder, and 2, shocked and surprised by the awareness that cannabis isn't a benign substance, that what they're doing when they're using marijuana has effects on the brain chemistry, on their brain circuitry, not only acutely, but potentially for the long term. And so I think that if there's something that I can have the audience take away from this talk, even though I'm going to go into maybe some of the more boring details of what happens with respect to the on a neurotransmitter level with respect to changes in dopamine or other neurotransmitters, which are chemicals in our brain, or with respect to the effects on brain circuitry and electrical signals, I think it's just to remember that there are sequelae to using marijuana, and it isn't a benign substance. So for this part of the talk, I am going to review some of the research investigating underlying neurobiological effects of cannabis with respect to changes in the brain. This is kind of a summary slide that tries to summarize key alterations in neurotransmitters based on rodent, non-human primate, and human studies. And I think that the main thing to notice, there's a bunch of different brain regions here, but most of them are implicated in the brain's reward circuit, which I'll talk about in a little more detail, as well as in the brain's cognitive control network or executive control network implicated in cognitive function. Some things to point out is that within the nucleus accumbens, which is a key reward center, we see that it acutely, on the left side, showing changes in terms of the acute effects, increases dopamine release. And so, like Dr. Norzi was discussing, what that does is allows people to feel a feeling of pleasure or acute sense of reward. That also likely results to increase in opioid peptides. It decreases GABA and glutamate, which are other neurotransmitters, in these reward centers. And the bottom figure is just showing the acute release of lots of dopamine. So it increases synthesis, it increases release into the synapse. But unfortunately, chronically, what we see with ongoing use is that there's a decrease in the receptor profile. So what happens is that our brains adjust to an ongoing use of a chemical that's causing an extra release of dopamine. And so there's a negative feedback which results in a reduction of the receptor profile where this substance binds to. And so ultimately that results in a decrease in dopamine release in response to rewarding stimuli in particular, as well as alterations that result in cognitive impairment in cortical regions such as the prefrontal cortex or PFC and the hippocampus, which is implicated in memory. Focusing in on the neurotransmitter dopamine, we know that dopaminergic neurons are modulated by the endocannabinoid system. And like Dr. Norzi mentioned, we have natural cannabinoids, what are called endocannabinoids, that our body naturally creates. But what happens when we use marijuana is that we can synthetically activate this system, and this is just a depiction kind of focusing in on a synapse level. So these are neurons, which are cells in our brain, and the synapse are the gaps between the neurons. And this is showing us how, in terms of the chemicals, in terms of how the cells communicate, cannabis results in a upregulation of glutamate, of GABA, which is the inhibitory neurotransmitter, and downregulation of glutamate, which is an excitatory neurotransmitter, which ultimately changes the receptor profile as well as release of dopamine within key reward and cognitive regions of the brain. This is looking more closely at the brain's reward circuit. As I mentioned, the nucleus accumbens in particular is a central hub which integrates different regions of this reward circuit that are involved in different aspects of reward processing. And when this circuit functions normally, it allows us to enjoy and experience natural rewards. So things like eating or drinking, intellectual accomplishments, and underlies our motivation as the driving force behind many of the choices that we make and the actions that we take in our daily lives. So dopamine is synthesized in the ventral tegmental area, and then it has projections to prefrontal cortical regions, to the nucleus accumbens, as well as other reward centers. And it's the key neurotransmitter involved in this circuitry. And as I mentioned, the endocannabinoid system plays a pivotal neuromodulatory role over the release and relative concentration of dopamine within this circuit. While there are over 100 cannabinoids present within cannabis sativa, the plant cannabis, delta-9 tetrahydrocannabinol, or THC, is the primary psychoactive component. And so all of these slides are really focusing in on THC and kind of its effects in these brain circuits. So why does this matter and why is this important? Multiple longitudinal studies have shown us that cannabis use increases the risk for psychosis. This is a study that was published in The Lancet in 2007, which collectively pools these longitudinal studies based in multiple different international locations, as well as the United States, which shows us that there's an adjusted odds ratio of 1.41, meaning 1.4, about 1.5 times greater likelihood of experiencing psychotic symptoms with any cannabis use, or in the case of users that were more frequent users, about twice as likelihood of experiencing positive symptoms as compared to individuals that didn't use any cannabis. Cyril D'Souza and colleagues at Yale University actually took healthy individuals that had not ever experienced psychotic symptoms and looked at what the effects of THC at different doses were with respect to what they would experience. And this is pretty much a summary slide of their findings, which showed that with a dose-dependent increase, so they looked at 2.5 milligrams THC, 5 milligrams THC in placebo, that the negative symptoms, so things like anhedonia, decreased motivation, decreased interest in social events, things that we collectively call negative symptoms of schizophrenia, went up as the dose of marijuana increased. And positive symptoms, similarly, so positive symptoms being delusions, hallucinations, also increased, and these are, remember, in healthy individuals as the dose of THC increased. And then they also found a corresponding decrease in function on a Hawkins verbal learning test, so as a measure of cognitive function as the dose of marijuana, of THC increased. This is important because it shows us that cannabis use is really considered a preventable risk factor for psychosis. And the longitudinal studies have really shown a consistent association, particularly with adolescent cannabis use and psychosis. Adolescence is now extended, arguably, up until age 25, because we know that our prefrontal cortex continues to develop up until our mid-20s, which highlights some of the dangers, in some ways, in today's political climate, when my Stanford patients are coming to me and are completely unaware of the potential dangers, including experiencing psychotic symptoms with marijuana use. A study in 2007 conducted by Eaton and colleagues showed that there's actually a lifetime prevalence of about 50% of high school students. So by the time they reach 12th grade, 50% of high school students have tried marijuana. This was in 2007, it might be higher now. And about 15% of 12th graders endorsed using marijuana regularly on an almost daily basis for at least several months at some point in their lives. In some ways, some of the data is still out, but we do know that in Colorado, from when they legalized the commercialization of medical marijuana in 2010 and recreational marijuana in 2014, they have seen, this is looking at emergency department and urgent care records in 13 to 21-year-olds, and they found that the annual number of visits with cannabis-related diagnostic code or positive marijuana urine drug screen more than quadrupled during this time. So now, looking into the neuroimaging aspect of what cannabis does with regard to dopamine. This is a study that looked at changes in using positron emission tomography and a radio tracer that was able to look at changes in dopamine concentration. And this is subtracting the activation within healthy controls to that within cannabis users, essentially highlighting that there was a significant decrease with respect to whole striatal. Striatal is a nucleus accumbens reward region, synthesis capacity of dopamine within the cannabis users that was significant, and that it also was related to the age of first cannabis use in these subjects. So how does this relate to cannabis use in particular in schizophrenia? We know that patients with schizophrenia are much more likely to also suffer from cannabis use disorder. They have about a 10 times higher lifetime prevalence as compared to the general population. And they, as a result, have a lot of exacerbated symptoms, as well as increased chance of relapse and hospitalization, poor response to medications. And unfortunately, we don't really have good treatments available for cannabis use disorder in schizophrenia. One thing that is interesting is that, in contrast to the amounts of cannabis used in the general population, patients with schizophrenia appear to use cannabis more chronically, but also in relatively more modest doses. But again, that's dependent on the availability of the marijuana that they can have. So despite the prevalence and negative impact of co-occurring cannabis use disorder in patients with schizophrenia, there's little empirical evidence with respect to the etiological contributors of cannabis use in this population. And it's important for us to understand the basis of cannabis use, as in why are patients with schizophrenia using cannabis more frequently in order to develop potential treatments for these patients. And the primary theory that's been advanced for many years is the so-called self-medication hypothesis, which proposed that patients with schizophrenia use cannabis as a means of ameliorating their negative symptoms. So, like I mentioned, their decreased motivation or anhedonia or apathy or flattened affect. Another theory that was proposed is that it's to lessen the side effects of antipsychotic medication. And we know that a lot of effective antipsychotics are antagonists of dopamine receptors in the brain. But we know that this can't be the whole story, because individuals with schizophrenia that use cannabis, in fact, have fewer negative symptoms, not more. And we also know that the prevalence of cannabis use disorder is higher in first episode patients, so even those that aren't on antipsychotic medications. So the likelihood that these are the driving causal factors for cannabis use is unlikely. So in graduate school, our laboratory focused on understanding what alternative model might better explain cannabis use prevalence in schizophrenia. And we focused on a reward dysregulation model, which proposed that perhaps reward circuitry impairment underlies elevated use of cannabis in schizophrenia, and that cannabis might transiently normalize underlying reward circuitry impairment. So is there any evidence for this? There is some. So this is looking purely at patients with schizophrenia that don't have a co-occurring cannabis use disorder. And investigators found, based on neuroimaging, task-based reward paradigms where they use stimuli such as beautiful faces, foods, pleasant smells, and probably most commonly monetary rewards. All of these are rewards that activate our reward circuitry. That essentially patients with schizophrenia, so in this case B, don't show the healthy activation of striatal and other brain reward regions that healthy controls do. And we also know that patients with schizophrenia show dysregulation within their endocannabinoid system, so within the natural cannabinoid system that we all have. They have decreased density of the cannabinoid receptors, especially within the prefrontal cortex, and this was found in post-mortem studies, so after patients with schizophrenia pass away and looking on autopsy post-mortem. Also in animal models of schizophrenia, they found reduced expression and function of these cannabinoid receptors, particularly in reward-related regions. So in our study, what we looked at is we took two groups of people. We took patients with schizophrenia that also met criteria for cannabis use disorder, and then we had healthy controls that had no diagnosable DSM disorder. And we randomized the patients into two groups. One group was looking at the patients received a 3.6% THC cannabis cigarette, and the other group received an oral THC marketed as Marinol or Dronabinol pill of 15 milligrams oral THC. Patients came in for a baseline fMRI scan after they were required to be abstinent from cannabis and other substance use for 1 week, and then they returned for a follow-up scan. This is showing an image. This is not a patient. This is one of our research assistants who is demoing our in-house bong that we essentially created for this study. There was a whole ventilation system that had to be set up in order for us to allow patients to smoke marijuana, essentially, within a research setting within the hospital at Dartmouth-Hitchcock. I think that one thing that I also want to point out here is that 3.6% THC, this is the average amount of THC that was in a marijuana cigarette in the early 1990s. But what's happening is that there's a lot of modification of plants because people want to market a higher percentage of THC. So the marijuana that people are using these days is not the same in many ways because there's a much higher concentration of THC, and a lot of times there's almost undetectable levels of cannabidiol, which, as Dr. Nordzi pointed out, has potentially antipsychotic properties that can help counter some of the psychotic sequelae of THC. So for clinical and safety reasons, we assessed for possible worsening of marijuana craving, of positive and negative symptoms, as well as additional physiological measures. And thankfully, we did not find any significant change induced with either cannabis or THC at the doses that we used. And I think that's important to highlight that if we even think back to the healthy individual study, looking at a high enough percentage of THC even in healthy individuals, you will start to see some of these positive symptoms. And what we found is that compared to healthy controls, this is a study looking at, it's an fMRI, so functional magnetic resonance imaging study, which indirectly assesses neuronal activation through BOLD signal, or blood oxygen level dependence signal. So it's looking at essentially how the regions of the brain are activated. And this is focused on the reward circuit, taking a seed region within the nucleus accumbens that I had mentioned. And what we found was that the healthy controls showed a lot more activation within reward-related regions and a lot more greater connectivity between regions of the reward circuit relative to patients. So essentially the bright red and the yellow is showing that. And you can see that with the patients, it's significantly lower. And then what we found was that the 3.6% THC cannabis, as well as the oral THC, increased functional connectivity within between brain reward regions. And this is just focusing in on prefrontal cortical regions and the connections with the nucleus accumbens. One thing that I will point out is that a lot of the patients that had smoked the 3.6% THC joint were convinced that it was a placebo joint. They were not high, they did not feel high, and they thought that this was for sure they were in the placebo group. So, and briefly, there were two other networks that we were really interested in looking at, and I'll just kind of go through the definition of what the default mode network is. It's an anatomically and functionally defined system that's preferentially activated when we're not focused on external attention. So when you're not paying attention to me to somebody giving a talk, in this case, myself giving a talk, when you're letting your mind wander, thinking about autobiographical memories, things in the past, things in the future, your default mode network is active. So it's spontaneously active at rest when we're engaged in internally focused thought. And what we know is that patients with schizophrenia have a hyperactive and hyper-connected default mode network. And it's been proposed that the abnormally elevated activation within this network contributes to misattributions of thought and to positive symptoms. So one can imagine that if this is a network that's activated when we're letting our mind wander, when we're internally focused, that when there's too much activation within this network, there may be a blurring of boundaries between internal thoughts and external events. And in healthy individuals, we see a nice switching between activation within the default mode network when people are letting their mind wander, and then a shutting down of the default mode network, and then kind of turning on, if you will, of what's called the cognitive control network or task positive network, when you are externally focusing your attention. And we see this nice healthy coupling where when one goes down, the other goes up, and vice versa. In patients with schizophrenia, there's an impaired network coupling, and we also see that there's what's called an anti-correlation, so a negative correlation between the task positive and default mode network, or task negative network. And that is associated with cognitive impairments in schizophrenia. So in our study, we wanted to understand and look at what the effects acutely of marijuana are on these two networks, in addition to the brain reward circuit. And what we found was that there was one, again, hyperactivation and connectivity of regions of the default mode network within these dual disorder patients as compared to healthy controls, and that's what the top row is showing us. That there wasn't a healthy anti-correlation or negative correlation between regions of the default mode network and the task positive network, in this case the dorsolateral prefrontal cortex, which is shown here in the second row in blue. And that the higher the connectivity within the default mode network, the higher the score on the PANSS, or positive, in terms of their positive symptoms in our patients. What we found with these relatively low dose of cannabis was that there seemed to be some improvement, at least acutely, with respect to the change in network coupling of these two networks. Again, this is a low dose, and it's an acute effect. So I think that's kind of the framework that we should be thinking about these findings. So in summary, we know that cannabis is not a benign drug. It has multiple effects on our brain in terms of multiple neurotransmitter systems and brain circuits. We know that acutely it increases dopamine release, but that chronically it results in a blunting of the dopamine system and a downregulation of cannabinoid receptors. We know that there's an increased risk of psychosis and psychotic symptoms with cannabis use, and that adolescents, up until at least age 25, are particularly vulnerable for this risk, and that cannabis use is a preventable risk factor for psychosis. In terms of cannabis use disorder and schizophrenia, we know that they're at much higher lifetime prevalence, about 50% prevalence of co-occurring cannabis use disorder and schizophrenia, that it worsens the course of schizophrenia, and that there appears to be a hypoactivation within the reward circuit that may be contributing to their use, and that as well as dysregulation within other neural networks, and that there are limited treatments available. There's a lot of area for future research, and I think that we're only starting to really understand a lot of the underlying neurobiology effects, especially with respect to chronic use and with respect to the differential doses of THC, as well as in combination with different percentages of cannabidiol and THC. But is there potentially a role for a low-dose cannabis or THC in treatment of schizophrenia, particularly in combination with cannabidiol? Is blunted dopamine release and synthesis seen in chronic users a pre-existing vulnerability factor or a direct result of repeated THC exposure? We still are trying to understand how gene variants modulate the endocannabinoid and dopamine systems and influence the sensitivity of the rewarding effects of THC, as well as vulnerability to addiction. And like I mentioned, understanding the complex dose-response effects of THC, as well as acute and chronic effects. Understanding mechanisms of regional differences in dopaminergic effects on functional significance of these behaviors, so particularly focusing on different regions of the brain, and what are the long-term effects of THC reversible with abstinence. These are just some references, and I will hand it back to Dr. Nordsey.
Thank you so much, Adina, for the deep dive into the science. And I was just going to wrap up to sort of bring that back to thinking about, as we've learned about this, brain reward circuit deficiency that can be associated with schizophrenia, and sort of how to understand that and think about how to help with that. So we know that that may be associated with experiences of sort of feeling emotionally distant or flat or blunted, maybe hard to feel as alive or engaged in the outside world, and this vulnerability to substance use disorders that we've just been talking about. So as we work with clients who are struggling with those experiences that we often characterize as negative symptoms, and especially if they've gotten into difficulties with substance use, we try to think about how can we help people to enhance their reward experiences and to engage with other ways of stimulating their brain reward pathway through social engagement, mindfulness interventions, physical exercise. You heard in the introduction that one of my other areas of interest is in physical exercise, and actually I first got interested in that decades ago in my first role at Dartmouth, working on treatment teams for caring for people with co-occurring disorders, as we worked with young folks who were running into cannabis and other substance use disorders as part of managing their schizophrenia and bipolar disorder. Then we found that helping those people to engage in physical activity was often one of the most effective ways to help them sort of get reward responses going again. And as I mentioned earlier, release of the endocannabinoids, those natural cannabinoid compounds, are part of our natural response to exercise. And so I'll talk to patients about that, especially patients who have a strong affiliation with cannabis, and to help them to think about how, if using THC is getting them into difficulties with managing symptoms, how they can get their natural reward system responding again with exercise. There's a lot of interest in exercise in schizophrenia currently because of findings that it improves cognitive function, which is what this review identified, as well as being helpful in managing negative symptoms and to some degree positive symptoms. And while nobody has studied brain reward in specific, this is a study I did with one of my residents at Dartmouth, looking at the before and after of people with schizophrenia, rating how they felt immediately prior to engaging in exercise, and then again immediately after they completed a workout, whether that was a run or lifting weights or that sort of thing. And so the difference here on a 10-point scale where they, this was actually on a 7-point scale where they were rating how great or exhausted they felt before and after exercise, and you can see they're endorsing substantial improvements in feeling great and feeling positive, terrific, strong, and less crummy, awful, discouraged. A lot of those really sound like the descriptors of reward, don't they? And so we obviously, the exhausted has to do with, the exertion that people have done, but we at least found some indirect evidence for, people with schizophrenia identifying sort of enhancements in reward in response to exercise. And again, sort of endorsing what we had been seeing all along, which is that helping people engage in physical activity helps them to bring their reward system into gear and sort of feel more alive and connected. So let us wrap it up there and turn it over to questions. We were just sort of, again, summarizing as Dr. Fisher did, that the brain reward circuit encourages repeating adaptive behaviors, but substance abuse can turn that circuit on and may lead to compulsive use. And we've established that people with schizophrenia may be more vulnerable to substance use because of that dampening of the brain reward system, which can contribute to cognitive and negative symptoms. That cannabis normalizes the brain reward circuit activity to some degree, but carries risks of worsening schizophrenia. And so the work around understanding the subcomponents of cannabis and how cannabidiol and THC may have separate effects is going to be important, and that should unfold over coming years. And helping people with schizophrenia and other psychiatric disorders to find healthy means to activate their reward system, including exercise and other, social and natural activities, will help them to be able to manage their illness better and to manage disorders in an integrated way, as Dr. McGovern started us off with. So let us wrap it up there, and I'll turn it back to Tara and Chris.